Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're in session number 6 of our new series entitled Orthopedic Essentials for the Qualified Medical Evaluator. And in this series, we're talking about true positive physical examination findings that would support your opinion for permanent impairment for injury to the spine out of Chapter 15, the upper extremity out of Chapter 16, and the lower extremity out of Chapter 17, all of the AMA guides. And in this program, we're discussing the importance of being able to properly identify true positive physical examination findings, because as we know, the AMA guides stress the importance of positive objective physical examination findings, and the AMA guides, while they don't discount, they tend to downplay the importance of examinee subjectivity in the provision of permanent impairment ratings. And interestingly, this is important because in the state of California, it seems that qualified medical evaluators have a tendency to overstate and overrate permanent impairment ratings. And I reference this claim by referencing a 2017 study by the Workers' Compensation Institute Review Board, which explains that in California leads the nation in the rate at which examinees who have been injured in the course of their normal work duties, those examinees in California go on in high percentage to receive permanent impairment ratings from either the primary treating physician or the qualified medical evaluator. So that it seems for some reason in the state of California, injured workers, despite competent and caring professional medical care, they have a tendency to fail to return to the pre-injury condition, and therefore they end up receiving a permanent impairment rating from the evaluating physician. Well, if that's true, the question can only become, why? Why is it that in California, so many examinees receive overstated and overrated permanent impairment ratings? Well, it has to do with the qualified medical evaluator's interpretation of physical examination findings. And so in this program, we're talking about true positive physical examination findings. And these are to be distinguished from examinees' subjective responses to otherwise objective test maneuvers. And in session 5 of this series, we began talking about true positive physical examination findings in the neurologic portion of the examination. And we started the discussion by reviewing the anatomy, by reviewing injury, and by reviewing physical examination procedures for the spinal nerve roots. And in that video, we concluded that reflex testing constitutes the only real, true, positive, objective physical examination finding. It seems that sensory testing is largely subjective, motor testing is largely subjective and based upon examinee participation, but reflex testing is one of the few true objective physical examination procedures that we have in our toolkit. So in testing for the integrity and function of the spinal nerve roots, you can confidently hang your hat on your findings of reflex testing. And in the presence of normal reflexes indicate that many structures, including peripheral nerves, including spinal nerve root afferents, spinal nerve root efferents, the spinal cord itself, even the end organ, all of those structures have to be functioning properly in order for the examinee to provide normal reflexes. So reflex testing is a critically important physical examination procedure that provides truly objective physical examination findings. And in today's discussion, we want to continue our physical examination procedures, now moving beyond the spinal nerve roots and into the named peripheral nerves of the upper and lower extremity. And remember from our last session, we reviewed the anatomy of the peripheral nerves, and we said that each and every one of the named peripheral nerves of the upper and lower extremity are formed through the combination of more than one spinal nerve root. So the named peripheral nerves receive contributions from as many as 2, 3, 4, even 5 spinal nerve roots. So in today's discussion, we're going to talk about the same sequence of topics that we covered with regards to the spinal nerve roots, and that has to do with the anatomy of the named peripheral nerves, injury to the named peripheral nerves, and then physical examination procedures in the evaluation of the named peripheral nerves of the upper and lower extremity. So with regard to anatomy, we're going to talk about the critical structures in and around the peripheral nerves, including the endoneurium, the perineurium, and the epineurium. And it's going to be important to understand these connective tissue layers, because the condition of these connective tissue layers and injury to these connective tissue layers determines the potential for recovery of the named peripheral nerves. We'll talk about the different types of injury that can be sustained by the peripheral nerves, beginning from the lowest level of injury known as neurapraxia to the next grade 2 type of injury, which is axonotmesis, and then finally the most serious of the injury classifications known as the Neurotmesis. And then we'll talk about the AMA guides and what the AMA guides tell us in terms of what's required in the physical examination of the peripheral nerves, including sensory testing, motor testing, reflex testing, and also neural tension tests. So let's begin now with a discussion of the anatomy of the named peripheral nerves. Okay, so here we have a cross-section of a named peripheral nerve right here. And let's just imagine this is the median nerve in the upper extremity. Well, it's interesting. If we look at the structures contained within this collective bundle that we refer to as a named peripheral median nerve, the peripheral nerves share a common anatomy with other structures in the body. For example, muscles have a similar structure and substructure as do the named peripheral nerves. Tendons also have a similar structure and substructure to muscles and also to named peripheral nerves, in that the whole bundle itself and many of the structures contained within the bundle are surrounded by protective connective tissue layers. So if we're considering the median nerve in the upper extremity, if we go to the smallest subunit contained within the named peripheral nerve, that of course would be the individual cell. So here we see one single axon of one single neuron contained within this named peripheral nerve. Now, if we're talking about a motor axon, we know that the nerve cell body of the motor axon is contained within the ventral root of the spinal cord at this particular segmental level of the spinal cord where this axon emanates. Could be C5, could be C6, could be in the ventral root of C7, C8, etc. If we're talking about a sensory neuron, we know that the nerve cell body of the sensory neuron is contained within the dorsal root ganglion of the dorsal root, again also at the segmental spinal level. Well, every cell in the body is surrounded by a plasma membrane, and axons are no different. So the first layer of protection that we have against axon damage, nerve cell damage, is the cell's own plasma membrane. Well, it's interesting because neurons, nerve cells, have an additional protective layer of protection, because the nerve cell membrane itself is again surrounded by another protective layer known as the myelin sheath. And the myelin sheath, although it's thin,
does provide some measure of protection against damage to the axon contained within that myelin sheath. And from there, we start to build additional layers of protective connective tissue structures. So surrounding the myelin sheath, providing an additional layer of protection, is the first connective tissue known as the endoneurium. And it's going to be important to understand the myelin sheath and the endoneurium, because varying degrees of injury to these two structures have tremendous impact on the potential for recovery of that injury. Okay? So here we have thousands and thousands of axons, each surrounded by a myelin sheath, and each of those myelin sheaths surrounded by a protective connective tissue layer known as the endoneurium. Well, all of these neurons are collected into a bundle, and then the bundle itself is surrounded by an additional secondary connective tissue layer, and this is known as the perineurium. So for example, right here, this could be a bundle of sensory neurons, perhaps bringing proprioceptive information up into the spinal cord from, say, the knee. This could be a series of mechanoreceptors in the joint capsule around the knee and the ligamentous structures around the knee, and all of these same similar functioning axons are collected up into a bundle, and the bundle itself is surrounded and protected by the perineurium. Well, within this named peripheral nerve, there may be hundreds and hundreds of different types and different functional classifications of axons. So we'll have motor bundles, we'll have sensory bundles, we'll have autonomic bundles bringing visceral afferent neurons into the spinal cord and distributing visceral efferents out into the periphery. And so within the named peripheral nerve, we could have hundreds and hundreds and hundreds of bundles. And here's a cross-section of a scanning electron micrograph, which shows different size bundles, each surrounded by the connective tissue layers. So here would be some perineurium structures. Here would be some endoneurium structures way in there deep, surrounding each of the individual nerve cells themselves. Well, and then the whole bundle itself, the bundle of bundles, is surrounded by its own connective tissue protective layer, and that's known as the epineurium. And as I said, this shares a similar structure with tendons and with muscles. In muscles, we have an endomysium, we have a perimysium, and we also have an epimysium surrounding bundles and bundles of muscle fibers. And then in tendons, we have similar structures. We have an endotenon, a peritenon, and then an epitenon surrounding the entire tendinous structure itself. So this is a recurring theme of protective connective tissue layers surrounding many different types of structures in the body. And for the purposes of our discussion today, we're talking about the named peripheral nerves. So the innermost structure, the endoneurium, this is a layer of delicate connective tissue around the myelin sheath of each myelinated nerve fiber. Its component cells are called endoneurial cells. So endoneurial cells are mitotically active and dividing cells. Their output product, the product that they produce, these endoneurial cells, is this connective tissue layer known as the endoneurium. The perineurium protects the nerve bundles by acting as a diffusion barrier to irritants, and also provides tensile or stretching strength and also elasticity to the nerve. Unfortunately, this tensile strength and this elasticity can be overcome and can be overwhelmed by tensile and stretching type of injuries. And we'll talk about a couple different types of those. Finally, the epineurium is a connective tissue layer. It's composed of loose or relar connective tissue. There's sort of a liquidy, fluidy, loosely arranged matrix that surrounds the entire nerve fiber itself. It allows for changes in longitudinal growth of the bundled nerve fibers without causing the bundles to be strained, without causing the bundles to be stretched, without allowing the bundles to be compressed. So these three connective tissue layers provide sequential layers of protection for the functional units of the individual nerve cells contained deep within the named peripheral nerve. Okay, so just to review, we have the endoneurium, the perineurium, and the epineurium. So if this is an individual neuron, we see here that we have the nerve cell body, and then we have the continuous axon creating a synapse here at a neuromuscular junction if we're talking about a motor neuron here. And so the axon is surrounded by myelin sheath, and then the myelin sheath itself is surrounded by the endoneurium. And it's these two layers, the myelin sheath and the endoneurium, that provide protection for the electrical conducting portion of the neuron, which is the axon. Well, according to Seddon, in Seddon's classification that he described in 1942, there's three basic levels and three basic severity gradients of nerve injuries. The first is known as neurapraxia. So with a neurapraxia, we have a transient, meaning it's temporary, a physiologic block, conduction block, a block of conduction of electrical axon potentials along the length of this axon, caused by ischemia from pressure or from stretch, in other words, tensile overload of the nerve. Now, with neurapraxia, we have no Wallerian degeneration, and we'll talk a little bit more about that in a minute. But Wallerian degeneration is not required with this level of nerve injury because there is no injury to the endoneurium or other structures, not distal but larger than the endoneurium. So a neurapraxia is a disorder of the peripheral nervous system in which there is a temporary loss of motor and sensory function due to blockage of nerve conduction. It's temporary. It usually lasts an average of 6 to 8 weeks before there's a full recovery. So this diagram here depicts a neurapraxia injury, and you can see that the axon here remains intact. You can see here that the endoneurium remains intact. The only disruption is to the myelin sheath, and we know that myelin is critical in quickening and accelerating the conduction of action potentials along the length of the axon. So in areas where we have a disruption in the myelin sheath, there's a delay or an absence of conduction, electrical conduction, across that gap, at least for 6 to 8 weeks, until this gap can be repaired. And it's repaired through the activity of the Schwann cells, which produce the myelin sheath. Okay, so there's the endoneurium again. The endoneurium remains intact, but the myelin sheath is disrupted. The next severity gradient of injury to the peripheral nerves is the axonotmesis injury. With an axonotmesis injury, the internal architecture of the nerve is preserved, but the axons and myelin sheath are so badly damaged that they have to be repaired, they have to be replaced and repaired. And that process occurs through Wallerian degeneration. But the architecture, including the endoneurium, the perineurium, and the epineurium, remain intact. And critically, it's the endoneurium, the intact endoneurium, that provides the scaffold or the architecture for the repair due to Wallerian degeneration. So this diagram here depicts the axonotmesis injury. The nerve cell body is intact. The axon, however, becomes damaged and decays and degenerates through Wallerian degeneration and has to be reestablished and reformed again, which takes place through Wallerian degeneration. And then as that axon is reformed, it becomes refortified by its myelin protective layer through the activity of the Schwann cells. But fortunately, due to the continuity of the endoneurium, the intact endoneurium provides the internal structure and the internal architecture upon which the Wallerian degeneration can take place. Now, in injury to the endoneurium itself, we then go on to the next classification and the most severe classification of peripheral nerve injury. Now, the most severe of the peripheral nerve injuries is the neurotmesis injury. With a neurotmesis injury, the structure of the nerve is destroyed by severing, such as cutting the nerve, such as by severe scarring, or prolonged severe compression. It's the most serious nerve injury in this classification scheme of Seddon. And in this type of injury, both the nerve and the nerve sheath are disrupted. So, for example, here we show that the axon is disrupted, the myelin sheath is disrupted, and the endoneurium is disrupted. And from here, this will not recover. This will not recover through Wallerian degeneration. The only way that this nerve injury can recover is through a surgical reconnection of the opposed ends of this neuron. So surgically, this endoneurium here is reattached to the proximal endoneurium through surgical sutures, and in this way the endoneurium is reestablished, and then subsequently axon regeneration and myelin sheath regeneration can take place, although it's typically quite slow, and in some cases it fails to be a complete return to function of this nerve cell. So with a neurapraxia, you can expect the examinee to report pain. There will be no or minimal muscle wasting. There will be no or minimal muscle weakness because of the transient nature of this level of injury. In other words, this injury does recover. It takes days to weeks to recover, but during this short time frame, generally is too short to have muscle wasting or muscle weakness manifest. But sensory symptoms such as pain, numbness, proprioception can be affected. And depending upon the degree of severity of this injury, recovery time can range from minutes to days to even weeks. With an axonotmesis, because the recovery takes place through Wallerian degeneration, the recovery time is much longer. The examinee will report pain now because of the length of time that it takes for recovery. Muscle wasting is evident. There will be complete motor, sensory, and sympathetic function lost, at least until the neuron undergoes recovery through Wallerian degeneration. The recovery time is generally months to even years because axons regenerate at an extremely slow rate, approximately 1 millimeter per day. So these symptoms are much more severe, much more functionally incapacitating, and take much longer to recover if there is full recovery ever. With neurotmesis, the only way that there is any recovery is through a surgical correction. Because the nerve is entirely severed, there will be no pain, there will be muscle wasting, there will be complete motor, sensory, and sympathetic functions are completely lost, at least until such time as some recovery takes place, but which can take place only through a surgical correction of the severed peripheral nerve. So that's a lot. So let's just quickly review these 3 levels of peripheral nerve injury. So with a neurapraxia injury, we have a focal demyelination as indicated right through here. Remember, the areas in between the myelin sheath along the length of the axon, those are known as the nodes of Ranvier. And with myelinated neurons, the conduction of action potentials along the length of the axon takes place by what we refer to as saltatory conduction. And I know this takes you back to your neurophysiology training in your professional schooling. So saltatory conduction accelerates the rate at which action potentials are conveyed down the length of this axon. Well, with a focal demyelination here, action potentials are either blocked and or delayed, at least until such time as the Schwann cells can regenerate the myelin sheath around this area of injury. So we have slowed conduction. Symptoms can range from actually no symptoms to transient sensory and motor symptoms. We can have weakness and sensory loss, but because it's usually a short-term injury, there will not be positive objective examination findings in the form of muscle wasting, loss of muscle tone, and or muscle weakness. So this is an examinee who may have some weakness in the absence of muscle atrophy. So typically we would consider those to be confounding findings, but in the immediate time period following this neurapraxia injury, muscle appearance, muscle tone, muscle bulk may be normal, and yet the examinee still may be unable to produce normal strength. With axonotmesis injury, we have a loss of the axon and also a loss of the myelin sheath, but the endoneurium remains intact distal to the area of the crushing or the stretching injury. So this is depicting a motor neuron, alpha motor neuron. The nerve cell body here is located in the ventral root of the spinal cord. Here's the end organ, which is muscle. This could be, for example, the quadricep muscle. And this is the neuromuscular junction formed right here. So the neuromuscular junction and the endoneurium remain intact, but the axon needs to regenerate and the axon needs to become remyelinated, and that takes place through the process of Wallerian degeneration. We'll go over that in just a minute. So an axonotmesis involves degeneration of axons distal to the lesion, so the muscle becomes functionally denervated. And symptoms include weakness, sensory loss, and now because of loss of innervation to the end organ, we're going to see atrophy becoming pronounced after the 6 to 8 week time frame. With neurotmesis, we have a nerve severing or a nerve laceration injury. We have damage to the axons and now also to the endoneurium, the perineurium, and the epineurium. And basically, this is a nerve that needs to be restructured and resutured back together in order that those connective tissue sheaths and tubes, the connective tissue tubes of the endoneurium, can provide a tube through which the axons and the myelin sheath can regenerate. So here we have a diagram of Wallerian degeneration, and this is going to apply to those axonotmesis and neurotmesis injuries. So here is a single individual neuron surrounded by the endoneurium here, and then here is an intact Schwann cell producing myelinated coverings around the axon here. And here's the area of injury contained within the center of the screen. Now with an axonotmesis injury, the endoneurium here remains intact. With neurotmesis, even the endoneurium is disrupted and it needs to be reestablished through surgical reconnection. So we can imagine this diagram as applying to either an axontomesis or a neurotmesis injury. In the presence of a neurotmesis injury, this endoneurium has been reestablished surgically. So let's just talk as if this was an axontomesis injury. So with an axontomesis injury, the endoneurium remains intact, but the myelin sheath and the axons have suffered injury. Well, when the Schwann cells and the myelin sheath become injured, of course, the cell ruptures and bursts and releases its contents into the extracellular environment, and that causes the attraction of macrophages into the area. Macrophages then go through the process of digesting and cleaning up this damaged area, engulfing particle matter, chemical matter through endocytosis, and clearing the area and creating a new fresh matrix upon which the regeneration can occur. So with Wallerian degeneration, we see increased activity of the Schwann cells, which start producing more and more layers of myelin. And the Schwann cells start to establish a continuity of myelination along this regenerating injured area, such that eventually the Schwann cells and the newly formed myelination, they form a regeneration tube through which then these new axons can be reestablished. So here's a cross-sectional diagram of this intact endoneurium, but newly forming and newly developing myelin sheath, which is going to eventually surround these new axon filaments being regenerated through this regeneration tube. So that over time and over the course of several weeks, the myelin sheath starts to develop newly, and it will eventually become segmented, forming new intersegmental nodes of Ranvier here. And the axon filaments will continue to coalesce into a single enlarging axon filament over the course of days and weeks, at which time this will be completely restored to normal structure and to normal function. And this takes place in both the axontomesis and the neurotmesis injuries, with the caveat that with the neurotmesis injuries, this endoneurial tube has to be reestablished surgically. So here we have our final end product. This axon has been reestablished. The myelin sheath and the electrical conductivity of that axon has been reestablished through the activity of adjacent Schwann cells and the reestablishment of a myelination along this injured axon. Okay, so let's talk now about the different positive objective physical examination findings that we can expect to see in the case of Neurapraxia, Axonotmesis, and Neurotmesis injuries. Now, because the named peripheral nerves carry mixed fiber types, in other words, they carry motor neurons, they carry sensory neurons, they carry sympathetic neurons, both sensory and motor, so we can expect to see changes in any or all of these functions. So on the motor side, some of the positive objective findings would include flaccid paralysis. In other words, inability to activate the end organ, the end muscular organ, and that would leave the muscle weak and flaccid. Because of loss of both sensory and motor neurons contained within the epineurium, we're going to see loss of reflexes, and this is a true positive physical examination finding. We're going to see muscle wasting and muscle atrophy at least after the 6 to 8 week mark following any of these grades of injury. We're going to see the lost synergistic action of muscles as muscles fail to function and fail to act coordinatedly through purposeful activity or purposeful motions. Over time, we're going to see fibrosis and contractures and adhesions of muscles as imbalances start to form around the joints. And as a result, we're going to see joint weakness and loss of stability around the joints. And you recall that much of joint stability is contributed to by muscle tone and the tone of tendons that cross joints. So we have both internal joint stabilizers and external joint stabilizers, and muscles and tendons form the external joint stabilizers. Well, in the case of loss of muscle tone and muscle strength, joint instability is a long-term sequel. Sensory symptoms, we're going to have various forms of dysesthesia, such as numbness, tingling, prickling, burning, aching, stinging, and all these various dysesthesias. We can expect also to see loss of vasomotor tone through involvement of the sympathetic efferents. This is going to cause warm, flushed skin in the early stages of loss of vasomotor tone. In the later stages, we're going to see overtone or hypertonicity of the vascular structures, which is going to lead to cold, white, and hypoxic looking tissues. The skin may be scaly, it may be thin, it may be smooth, and it may be shiny in the later stages. And we're going to expect to see various forms of trophic changes. Trophic changes is a term used to describe abnormalities due to loss of function of the sympathetic neurons. And we're going to see, for example, wasting away of the skin or thinning of the skin, thinning of the tissues, wasting of the muscles, osteoporosis of the bones, and changes in how the hair and nails grow, including thickening or thinning of the hair or brittle nails. We're going to see dryness of the skin due to loss of function of the sweat glands and loss of the pilomotor response. In other words, loss of lubrication of the hair follicles through the sebaceous glands, and also lack of erection of the erector pili muscles, because those erector pili muscles are innervated by sympathetic efferent neurons. So these form the basis of true positive objective physical examination findings that can be observed directly by the eye. So loss of pilomotor response is something that you can observe through careful observation. Vasomotor changes are something that can be observed through direct observation. And then through manual muscle testing and through sensory testing, we can pick up true positive objective examination findings due to loss of sensory and loss of motor function. So here is table 1612 from the AMA guides. And the AMA guides give us all of the muscular and sensory areas innervated by each of the named upper extremity peripheral nerves. So I just want to go through these tables very quickly as an example to show you how you can quickly conduct both your sensory and motor testing of at least the upper extremity named peripheral nerves here. So first of all, for the musculocutaneous nerve, we know that the musculocutaneous nerve is motor to the coracobrachialis, the biceps brachii, and the brachialis, and at least these two, the biceps brachii and the brachialis, we know that those are strong elbow flexors, and they're the primary elbow flexors, contributed also by other weaker elbow flexors such as the brachioradialis and some of the forearm muscles that do cross the elbow joint. But these are your main elbow flexors. So to test the musculocutaneous nerve, we simply test for resisted elbow flexion through the biceps brachii and the brachialis. For sensory, the musculocutaneous is sensory to the anterolateral half. So picture yourself in anatomic position, which is your arms to your side, palms facing forward. The anterolateral half and the posterolateral third, so that's basically over the anterior and posterior radius bone in the forearm. So that's the sensory area. So you might just take your pinwheel down the lateral aspect of the radius bone and you'll cover the entirety of this autonomous zone for the musculocutaneous nerve. For the axillary nerve, we know that the axillary nerve is motor to all three heads of the deltoid muscle, the anterior, middle, and posterior heads of the deltoid muscle. So to test the axillary nerve, we test the deltoid muscle. Primarily, we test resisted shoulder abduction. Resisted shoulder abduction. But you could also test shoulder flexion. You could also test shoulder extension. And then it has a very specific sensory distribution over the lower half of the lateral deltoid. So you would simply run your pinwheel or your Semmes-Weinstein monofilament over any aspect of the deltoid muscle, all of which is innervated by the axillary nerve. For the radial nerve, very simply, we want to test resisted wrist extension because we know that the radial nerve is motor to the extensor carpi radialis longus and also the extensor carpi radialis brevis. So it's perfectly suited and perfectly amenable to resisted wrist extension testing both of these strong wrist extensors. It also has a very specific and easily tested sensory area, which is over the posterolateral half of the wrist and hand. So picture yourself again in anatomic position. The posterolateral aspect of the wrist and hand is really over the dorsal radius bone near the articulations of the wrist carpal bones and the carpal metacarpal joint of the thumb. So the posterolateral wrist and the hand. This is an area of the wrist and the hand where handcuffs can be tightened too tightly and compress the radial nerve over the posterolateral radius bone and cause a sensory disturbance in that area due to too tight handcuffs or too tight of straps around the wrists. Okay, so those are the sensory and motor areas of the musculocutaneous, axillary, and the radial nerves. For the musculocutaneous nerve, we also have a reflex, which is the biceps reflex, which again, we also tested that through testing C5 nerve root. So this is perfectly tested in assessment of the musculocutaneous nerve. And then for the radial nerve, we have both the triceps reflex, okay, and I won't take the time to spell it, but we also have the extensor digitorum reflex. The triceps reflex is a C7 reflex, whereas the extensor digitorum is a C6 reflex. But both of those reflexes are mediated through the radial nerve. There's C6 and C7 there. So interestingly, with the extensor digitorum reflex and the triceps reflex, both of those are mediated by the radial nerve, but they're mediated by different nerve roots contained within the median nerve. Okay, let's go on now to the ulnar and the median nerve. With the median nerve is motor to the muscles of the thenar eminence of the hand. The thenar eminence of the hand is composed of the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. So, good way to test the median nerve in, for example, cases of claimed carpal tunnel syndrome, for example, is to test the abductor pollicis brevis or the opponens pollicis. To attest the opponens pollicis, simply have the examinee take the tip of their thumb to the tip of the pinky finger and attempt to pull apart these two fingertips by applying pressure to the thumb, making sure to apply only stabilizing pressure to the pinky finger because we're testing the opponens pollicis of the thumb. Also, there is an opponens digiti minimi, but the opponens digiti minimi and testing the pinky finger opposition, that's through an ulnar mediated muscle, ulnar innervated muscle, whereas the opponens pollicis is innervated by the median nerve. So quite simply, if you want to test both the median and the ulnar nerve, you can test thumb to pinky finger opposition. To test just the median nerve, you would apply your pressure, your manual muscle testing pressure, to the thumb only. Okay? So those are two purely median nerve innervated muscles, the abductor pollicis brevis and the opponens pollicis. So you can simplify the entire median nerve motor testing procedure to either one or both of those muscles. And then for sensory testing, we know that the median nerve is sensory to the first, the second, and the third palmar web spaces. So you can simply run your Semmes-Weinstein monofilament down each of those web spaces to test the median nerve. The median nerve, we do not have an associated reflex associated with the median nerve. So there is no reflex testing for the median nerve. On an objective basis, due to long-term injury or even damage to the median nerve, we're going to see atrophy of the thenar eminence of the thumb due to atrophy of these three muscles, the abductor pollicis, the flexor pollicis brevis, and the opponens pollicis. With the ulnar nerve, it's tested quite simply because the ulnar nerve is motor to all interossei muscles. That's both the palmar and the dorsal interossei. So you would simply test resisted finger abduction to test the dorsal interossei and resisted finger adduction to test the palmar interossei. And then for sensory testing, we know that the ulnar nerve is sensory to the palmar ring and pinky fingers. So the best place to test that is to test the ulnar aspect of the pinky finger and the hypothenar eminence of the hand. And that covers the entire sensory testing for the ulnar nerve, because this area, the ulnar aspect of the pinky finger and the ulnar aspect of the hand, is what's known as the autonomous zone for the ulnar nerve. And for the ulnar nerve, we do not have an associated reflex testing, so our physical examination procedures are limited to sensory and motor testing, and also to observational findings such as atrophy of the hypothenar eminence in cases of long-term compression injury to the ulnar nerve. Now, in addition to observation, in addition to sensory testing, in addition to motor testing, and in addition to reflex testing, it may become valuable and necessary to perform various neural tension tests in the assessment of upper and lower extremity peripheral nerves. And you're familiar with many of these neural tension tests. So we have, for example, upper limb tension tests. The straight leg raise test is a form of a neural tension test. The slump test is a neural tension test. These are referred to in the AMA guides as sciatic nerve tension tests, but there are tension tests for all of the named peripheral nerves of the upper and lower extremities. And the philosophy of the neural tension tests is that when there's a loss of extensibility meaning there's a fixation or an adhesion or a restriction to movement of the nervous tissue at one site, it may produce increasing tensile loads when the peripheral nerve or nerve root is stretched at another site, which then leads to mechanical dysfunction. So with the straight leg raise test, we have a loss of extensibility of either the spinal nerve root or the peripheral sciatic nerve, either at the spine due to a disc lesion or perhaps at the piriformis muscle due to a piriformis muscle entrapment syndrome. And these tests put neural tissue, such as the neuraxis of the central nervous system, such as the meninges, such as the nerve roots, and even the peripheral nerves in the case of a piriformis syndrome or an ulnar cubital tunnel syndrome or a median nerve carpal tunnel syndrome, for example, puts these tissues under tension and may duplicate symptoms that the examinee reports that they experience during their day-to-day daily living activities and their day-to-day work activities. So with the neural tension test, because so many doctors employ neural tension tests in their physical examination procedures, it's important to understand what comprises or what consists of a true positive objective physical examination finding in the presence of a bona fide nervous tissue lesion. So with neural tension tests, the patient is often aware of increased tension or discomfort in the spine or limb. And what do you think would be the expected behavior of the examinee who experiences increasing tension or increasing pain or increasing pulling in the spine or the limb of the upper and lower extremity? What would you consider to be a true positive examination finding for this particular examinee? Well, because tension tests indicate neural mobility and sensitivity to mechanical stresses, they are considered positive only under a couple of situations or circumstances. Number one, only if they reproduce the patient's symptoms and if the patient's response is altered, meaning their symptoms are increased or decreased, by movement of a body part distal to where the symptoms are felt. So for example, if we're talking about the straight leg raise testing as a neural tension test, when we raise the leg to, say for example, 45 degrees, and the examinee reports pain at 45 degrees elevation of the leg relative to the table, if we then employ foot dorsiflexion, which causes increasing tension along the neural structures and the neuraxis, the examinee should report a sharp increase in symptoms in the spine or the limb. And conversely, if we reduce the tension on that neural structure by employing foot plantar flexion, that should result in a relief of the symptoms in the spine or in the affected lower extremity limb. So you can employ these compensatory movements as confirmation procedures to test the true positivity of the examinee's subjective complaints of increasing pain, increasing tension, or increasing discomfort in the spine or the limb. Similarly, in the case of a bona fide lesion of the spinal nerve root or the named peripheral nerve, if we consider that pain, true bona fide pain, involves some form of evasive action, when we have a true positive neural tension test, the examinee should demonstrate some form of evasive action away from the pain. So in the case of the straight leg raise test, what would be an example of evasive action away from the pain? Well, one way that the examinee can get away from the pain would be to lower the elevation of the leg. So as the examiner starts to elevate the leg approaching 45 degrees, once that pain hits the examinee will reflexively extend the hip, bringing the leg back down closer to the table. thereby relieving tension on the nervous structures. What would be another way that examinees could demonstrate evasive action away from the pain? Well, another way that examinees evade the pain is by flexing at the knee. By flexing at the knee, that causes a release or relief of tension on the neural structures, and it's one ways that examinees manage to pull themselves out of the impending clutches of increasing pain as a result of these neural tension tests. So always be aware of these subtle and profound demonstrations of evasive action by the examinee, and cleverly and carefully employ your confirmatory testing procedures by moving a body part distal to where the symptoms are felt. And in movements that increase the tension on the neural tissue, the examinee should report increasing pain. And with maneuvers that decrease the tension on the neural tissue, the examinee should consistently report a relief or a diminution in their painful symptoms. And you can use these as confirmatory testing procedures to assess the true positive or the true positivity of these objective tests. Okay, here is figure 1647 from the AMA guides, and just to review, in going through our manual muscle testing, our motor testing, our resisted manual muscle testing of the upper extremities, for the axillary nerve, we're going to assess the deltoid muscle through resisted shoulder abduction. With the musculocutaneous nerve, we're going to assess the biceps and brachialis through resisted elbow flexion. With the median nerve, we're going to assess the hypothenar muscles. The thenar muscles, especially the abductor pollicis brevis and the opponens pollicis brevis. With the ulnar nerve, we're going to assess the palmar and dorsal interossei muscles. And then for the radial nerve, we're going to assess resisted wrist extension through the extensor carpi radialis longus and the extensor carpi radialis brevis. Okay, so let's conclude this discussion of the physical examination procedures for the spinal nerve roots and for the named peripheral nerves of the upper and lower extremities. And let's just summarize by saying that when you have a bona fide dysfunction of neural tissue, you can expect to see sensory and motor changes. Now, unfortunately, sensory and motor changes produce subjective responses from the examinee. And so the findings on sensory testing and the findings on motor testing can many times be unreliable and inaccurate because they're largely based upon examinee's subjectivity. Now, there are some true positive objective physical examination findings that suggest motor dysfunction, and there are some true positive objective physical examination findings which suggest true and bona fide sensory dysfunction. But the most reliable and the most of the objective findings reside in the presence or absence of autonomic signs and symptoms, and also by the presence or absence of reflex changes. I especially like reflex testing because reflex testing is a truly objective physical examination procedure. But similarly, like reflex testing, you can rely on findings on observation for autonomic signs and symptoms, such as dryness of the skin. That's a true positive objective physical examination finding, which suggests loss of sweat gland function in the sweat glands innervated either by the spinal nerve root in question or by the named peripheral nerve in question. Other trophic changes, such as loss of pilomotor reflex or pilomotor response, vasomotor changes, nail changes, brittleness of the skin, brittleness of the nails, thinning of the hair. These trophic changes say 1,000 words about the innervation of the structures that rely upon a full and uninterrupted nerve function. So unfortunately, we don't have reflex testing for every segmental level of the spine. We only have spinal reflexes for C5, C6, and C7 in the cervical spine, and for L4 and S1, L4, L5, and S1 in the lumbar spine. But when you have normal reflexes in these 6 reflexes, that tells you a lot about the function of the structures contained within each of those reflex loops. In other words, a lot of structures have to function properly in order for the examinee to provide normal reflexes. So you can hang your hat on your findings on reflex testing and also on your observational findings for the presence or absence of autonomic signs and symptoms. So that concludes our neurology discussion. In our next session, we're going to talk about true positive physical examination findings in the physical examination of the joint structures of the spine and of the upper and the lower extremity. So for today, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's video. Look forward to being with you on our very next session as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.